All right. So chapter 9. So this kicks off airway, right? We got chapter 9 and chapter 10. So with that, today we're going to talk about airway management, which is first step of the two parts of airway, right? Thursday, then we're going to have a chat about oxygen administration and how to deal with adequate and inadequate breathing. But this is all airway. If you've looked at your skill sheets ahead of time, you'll know that this is a big piece of your patient assessment, okay? Application-wise for real world, this is the most important part of your job after your own personal safety, okay? This is your biggest priority with patients. And the frustrating thing for us as providers, this isn't like a checkbox. We don't go, yep, airway's good, and we move on and never have to look at it. This is something you're always having to reassess. We start doing scenarios and stuff, it won't be uncommon for us as evaluators to make the airway change halfway through the scenario to see if you pick up on the fact that it's changed, okay? Because real-life patients don't tell you, hey, I think my throat's closing all the time, right? Sometimes it just closes and they go unresponsive and you have to pick up on it, okay? The term right here, open it, clear it, and maintain it, is something that needs to go through your head when you're talking about airway, okay? Step 1's open it. Step 2, clear it, so suction it or whatever. Step 3 is maintain it. If they'll maintain their own airway, great, then just leave it alone. If they don't maintain their own airway, you got to get a little more aggressive, okay? This is probably one of the biggest issues that paramedics have is we still teach them start with the basics, right? We still want you to go with the most basic maneuver possible. They want to skip and move on to a little more advanced stuff. Airway all starts at the very basic. What is the very most basic way to open an airway? Open the mouth, right? That's where all of your airway maneuvers need to start, either head tilt, chin lift, or jaw thrust, which we'll talk about. Then you can start thinking about nasal airways and oral pharyngeal airways. Then you can start thinking about King Airs or combi tubes or LMAs or iGels, which we'll talk about all of those. And then paramedics can start thinking about ET intubation and stuff along those lines, okay? So kind of a reminder of the AMP and stuff that we're talking about. Your upper airway is everything from your glottic opening up, okay? Mouth, nose, the pharynx, the oral pharynx, the nasal pharynx, the laryngeal pharynx, all that's the upper airway, okay? If we're talking about gurgling or stridor or snoring or anything of those, we're talking about an upper airway problem, okay? When we talk about lower airway, it's everything from the glottic opening, or basically the top of your trachea, all the way down, okay? Bronchial constriction, rales, rhonchi, wheezes, those sounds we'll talk about on Thursday. All those sounds are found in the lower airway, okay? Have an idea what's considered to be upper and what's considered to be lower, okay? This right here will be pretty important for you on Saturday, okay? I will tell you that not everything on here you're going to have to know. I'm not going to tell you what you don't have to know because it's all important, okay? I wouldn't be surprised if this exact diagram is not on your test on Saturday, okay? It's going to be there, so get to know it. Tongue is this giant thing right here, okay? This is that glottic opening, right? We talk about King Air later. We'll talk a little about today, but mostly on Thursday. I want you to keep this in mind because the common misconception about King Airs, which is a supraglottic airway that you'll get out of this class, is it's a tube that actually goes and sits in your esophagus. Okay, the end of the tube has a balloon on the end and a balloon about a quarter of the way up from that. One balloon inflates right here in the esophagus and blocks off the esophagus. The other balloon inflates in this oral pharynx area. So when you use that BVM and air gets pushed, it goes in between those two balloons, which air is forced to go in the trachea. Okay? That's one of the ways that we give you as EMTs to provide an airway to someone who can't control their own. The only time you get to use it is unconscious, unresponsive, or cardiac arrest. Okay? They can't be breathing their own. They can't have a gag reflex. Now, paramedics can go a little more invasive. They get what's called endotracheal intubation. They take a tube and one of those blades that you see in all the movies, right? The blade goes in their mouth. They actually look down that blade and they can see the vocal cords, okay? Their tube passes through the vocal cords and actually sits inside the trachea. We consider that to be what we call a definitive airway, okay? Because your trachea and all this stuff right here can swell around that ET tube, and we can still provide ventilation to them. Does that make sense? Your supraglottic airway is not a definitive airway. because it sits in the esophagus, which means all this tissue can still swell closed, and we won't be able to use that BVM. Does that make sense? ET intubation is the most preferred airway in the paramedic setting, okay, because it's definitive and it's a guaranteed secured airway, unlike our supraglottic airway, which isn't considered that. So we talked about the lower airway, right? It begins at the larynx, or right there at the top of the trachea, and then composed of trachea, brachial passages, and the alveoli, okay? Again, don't forget to make sure you understand the upper airway and lower airway. Make sense to everybody? Pretty easy, pretty straightforward stuff. Brandon's even yawning. 6:15, man. Got a long ways to go. All right, this diagram right here will also be very, very important for you on Saturday. Okay? The difference between this diagram and the one that you may or may not see on Saturday is the one that you may or may not see on Saturday has a set of lungs attached to it. Okay? Pay very close attention where the larynx is, where the trachea is, what's considered to be mainstream bronchus, what's considered to be secondary bronchus. There's the tertiary bronchus, then there's the bronchioles, right? And then, of course, don't forget the carina, which is that bifurcation or split of the trachea becoming those two bronchuses, okay? Notice that mainstream is that first pipe. There's a right mainstream and a left mainstream. After that, we quit counting because it starts breaking off into the secondaries and then into the tertiaries, and then the very small ones are the bronchioles, right? Anytime you add I-O-L-E is when we're talking about smaller versions of. Does that make sense to everybody? So the alveoli, we talked about this in A&P, but these are those tiny little grape-like sacs. This is where that exchange happens, right? They're surrounded by what? Capillaries, right, which is where you exchange that CO2 for oxygen, okay? This is a constant movement of fluid. So when we start talking about congestive heart failure in a couple of weeks, remind yourself that cardiac problem does have some respiratory consequences, okay? Am I going too fast? Are we good? Good? All right. So this is just a look at them, right? So these are surrounded by the capillaries on the outside of this. Those are little sacs. What happens is those capillaries lead to your cardiovascular system. So if fluid backs up, it ends up in these pockets. Okay? These pockets fill full of fluid that then will fill this full of fluid that just travels its way up, and then it feels like you're drowning in your own fluid. Okay? Doesn't sound very nice, nor is it nice for them most days. Okay, so here's the pathophysiology of the airway. Obviously, there's a ton of different stuff that can interfere with the airway. What is the most common airway obstruction? Your tongue. Okay? Don't forget that. You will see that over and over again throughout this class. Most common airway obstruction is your tongue. Now, the reason is by having altered mental status, you have poor muscle tone that allows that tongue, I'm going to go back just for a second, allows that tongue, these muscles right here, to slide back and occlude your airway. All it takes is for you to head tilt, chin lift them, or jaw thrust, and it slides those muscles forward, okay? Sometimes it's that simple, okay? It'll blow your mind of how little you really have to do to fix someone's airway in some of those circumstances. So foreign bodies, food, small toys, stuff along those lines, liquids, blood, vomit. We're going to talk about suction, how to suction, why to suction, when to suction, all that good stuff here later this evening. But those are kind of those definitions. Acute and chronic. You know the definition difference from the two of them. Acute means what? Say again? Nope. What's that? It is serious. That's not the definition. Sudden onset, right? It happens right now. Acute chest pain is something that happens right this very second. Chronic chest pain is, well, I get this chest pain that comes and goes every few hours or whatever. Does that make sense? So acute is something that happens right now, and chronic is something that happens over a period of time. Okay? The other thing to remember is you initially evaluate airway, and then you need to monitor its patency. What does patency mean? Open and clear, right? Over a period of time. I will tell you best practice, if you've got 2 or 3 people on your team, or in this case, I think we're going to put you in teams of 4 or 5, put someone in the airway position. So that is their one and only job, right? Always looking at airway. Now, if the person's conscious and alert, maybe the person who's the airway person can be the one asking questions, because one of the very best ways to find out if they have an open airway is talk to them. They can talk back to you, their airway's open, okay? In a cardiac arrest circumstance, put someone at the head and make them in charge of just the airway. Okay? We'll talk about the way, tunnel vision works, not probably next week, if not the week after. If you give someone too many jobs, they're going to drop the ball on something. Okay? So if you're in charge of running the AED and keeping track of how long we're doing chest compressions and taking care of their airway, they're going to lose their airway. It's going to take you 30 seconds to a minute to figure it out. Does that make sense? So if you're the airway physician, then make that your one and only job. So here's a list of acute problems with airways: foreign bodies, vomit, blood, stuff along those lines. Teeth is also fairly common in the trauma circumstance. And then occurring over time, edema from burns, trauma, infection, or that decreasing mental status that progressively leads to an occluded airway. Does that make sense? Good thing. Okay, bronchoconstriction. So this is an airway problem, right? It's a lower airway problem. This stuff right here, this is normally an upper airway problem, right? This is a lower airway problem, okay? If you break it down, constriction meaning it gets smaller, and it's telling you the location of where it's at, right? So it's just the bronchial tubes, whether it's the primary, the secondary, the tertiary, or whatever, the smooth muscle causes them to constrict, and it causes air not to pass like it's supposed to, okay? This is pretty common with what type of medical condition? Someone take a guess. Asthma. COPD is the other one, right? So this is what your inhalers, your rescue inhalers, are meant to flip over, okay? The other one is in anaphylaxis, this is what histamine does to you. The histamine released by your immune system causes bronchoconstriction, okay? Don't you hate when the whole slide is red? So patient assessment, we're going to beat this to death, okay? There's a couple of different sections of your patient assessment. One is the scene size up, okay? That's all the safety stuff, the resources, the personal protective stuff, all that. Once we get into the primary patient assessment, we're now worried about our patient, okay? So your airway is addressed during patient assessment, always. Does that make sense to everybody? Okay? You have to complete your primary assessment in these scenarios before you can move on to your secondary, where it's an automatic critical fail. Okay? In your primary assessment, it's basically airway, breathing, circulation. As long as you treat those three things or assess those three things, you're squared away. So, with the airway, very first question is it open? Okay? If it is open, the question is, will it stay open? Okay? This is head tilt, chin lift, jaw thrust. Will the airway stay open? We start talking about OPAs and NPAs. Okay? We're going to get more into when to do it, when not to do it here in a second. When you start your care, right? So, okay, airway's open. That's awesome. Now, after airway comes breathing, and the question is their breathing adequate? That's what all of Thursday is about. Okay? Are they breathing adequately, or are they breathing inadequately? Okay? This magic question right here is the one that we're going to beat to death on Thursday, because no longer do we just give oxygen because we can. Okay? There are some pretty severe things that you can cause if you give pure oxygen to every single person you come in contact with. Okay? There are people who need it, and there are people there's absolutely no reason to give it to them. Okay? So, is it open? Is their breathing adequate? And then do they need oxygen? Okay? You might put in those circumstances where the evaluator says their saturation's 94%, and you say, okay, great, and they say, okay, they're conscious and alert, they're not complaining of shortness of breath, and you say, okay, I don't want to put any oxygen on them. And the evaluator might ask you, why not? Then justify it, right? We're going to ask you questions like that to see if, are you just working to the motions, or do you actually know the reason why you give oxygen, or the reason why you don't give oxygen, right? So get to know why you give drugs. Is oxygen a drug? Absolutely, right? It has side effects. It can cause damage. It's a prescription, right? Us as ambulance providers, as EMTs and paramedics, we have it because it is a drug, okay? So get to know it just like you would any other drug that we're going to talk about. So looking at the airway being open, the easiest way is, hi, I'm Sean, I'm with Deer Park Ambulance. Can I help you? If they say yes, the airway is open, right? Pretty easy, pretty straightforward. Talk to your patients. If they are face down, can they control their own airway adequately? No, roll them over, right? Is it an emergency move? Depends on the circumstance, okay? Patients who are face down or patients who are facing a wall or whatever, now if they're on their side but facing a wall, can they control their own airway? Yes, but can you adequately assess their airway? No, so move them. Does that make sense? Make that decision, pull the trigger early with airway. Either fix it or allow it to be adequate where it's at. The best place for them, if they're unconscious, is flat on their back so we can take care of it. Now, when you transport them, you can put them on their side, but initially roll them over, let's check the airway and go from there, okay? This sniffing position is where we see a lot of patients that have swelling somewhere in their airway, and basically they just tip their head back is all they do, right? It's like if something's in the air that you want to smell, it's like tipping your head up and trying to smell it. That's the sniffing position, okay? I left this term here because when we do airway stuff, when we drop our king air, we want our patients in the sniffing position, okay? This is a good red flag. If you walk in the door and they're in the sniffing position, they have their hands on their knees and they're bent over in the tripod position, and they're breathing like 2 to 3, or they're talking in 2 to 3 word sentences, it's the dumbest question ever when you say, are you having difficulty breathing, right? You can look at them and determine they're having difficulty breathing. The sniffing position with this term mostly for airway control. So, findings that indicate breathing problems. If they can't speak, it's an airway problem, right? If they got an unusual raspy quality to their voice, how are you going to find out if it's unusual? Yeah, family, even ask the patient, right? Because if you've never seen that person before, their unusually or their raspy voice might be something they always have. Okay? Stridor, what does it mean? Stridor is what? So it's a breathing sound. Is it upper or lower? Try again. Upper. It was 50-50 chance. Nice work. So it's an upper airway problem, right? It's a high-pitched whistling sound. Okay? This is like blowing across the top of a beer bottle. Not that I've ever done that because I don't drink alcohol, but my friends tell me that it sounds the same. Half this class is like, I know you, and that's all a lie. So how do you fix it? How do you fix stridor? What do you think? What causes it? Let's go there. So we know what it is. We know what it sounds like. What causes it? Say again? Blocked airway, right? A lot of times it's food, it's a foreign object, right? That just decreases the size of your upper airway and causes the wind when you exhale or inhale to make that whistling sound. So the only way to fix this is remove the object. Okay? Snoring, besides sleeping, what does this mean? What's the problem here? What do you think? What's causing it? Your tongue. So how do you fix it? Head tilt, chin lift, jaw thrust. Okay? Gurgling, what are we dealing with? Liquid, right? It's blood, vomit, whatever. So how do you fix it? Suction. Those 3 things I would never forget. If it's stridor, there's something in their airway. Okay? If it's snoring, it's their tongue. Head tilt, chin lift, jaw thrust. Okay? If it's gurgling, suction it, control their airway. Just don't forget, open it, clear it, maintain it, right? If you're suctioning, that's the middle step. Don't forget there's a 3rd step. Okay? You still want to maintain that airway after you've suctioned. Okay? This is what stridor sounds like. So in this case, it's a medical condition, but hear that high-pitched sound? What do you notice this kid's trying to do? Yeah, he's trying to sit up. What is mom doing? Trying to pull him back, right? We don't pick up on those things. Kids, I know they're young and they don't know what they're doing. Their body knows exactly what it's doing, right? That kid the last position that kid wants to be is flat on mom's stomach, right? Lift that kid up, sit him forward. If this is an adult, the same thing. Believe it or not, we do this to adults all the time, right? They're having respiratory problems and we sit them on our stretcher and they're sitting too low on the stretcher. So what do? We lay the stretcher down. We lay them flat, and we try to scoot them up. And the second you lay them flat, they start doing that flailing thing. And providers are like, don't worry, we're going to stitch you up in a second. No. Figure it out a different way. Then don't lay them flat. Okay? The last position these kids or these adults want to be in is flat on their back. Listen to it one more time. Feel bad for him. What else do you notice about his chest and his stomach? So his stomach's moving a ton, but babies are belly breathers, right? So that's pretty normal. What else? I heard something else over here. Nothing? Yeah, so you got maybe a hernia or something right here, right? Umbilical hernia is pretty common in kids. I'll let you watch one more time. Now, forget the position. I want you to watch what his body's doing. Okay? Look right here. Okay? Watch. We'll go back to the beginning because they won't hold still. See it? Those are called intercostal retractions. Okay? Now, adults, when you breathe, we're used to using our intercostal muscles because we don't rely on our diaphragm. Okay? Kids are opposite. Kids rely on their diaphragm and less on their intercostal muscles. So when you watch this kid breathe, this is a huge red flag. Okay? They're working way too hard to breathe. Now, the good thing about adults is if we have a hard time breathing, then our bodies will work on it, right? Hard time breathing, we start being like, okay, so we're losing lack of oxygen, so our cardiovascular system will kind of kick in and help out. Babies will struggle to breathe until their body gets so tired, and then their body just gives up, right? So this kid right here, you let him go for 2 or 3 hours like this, and he'll just quit breathing. So you got to it's aggressive, right? As an EMT, the downfall is he's conscious, therefore you're not going to put in the OPA. I highly doubt you can convince this kid to put an NPA in. So put him in a position that allows him to breathe, and you transport him as quick as the hospital as you can get him. Okay? But you got to pick up on those red flags, those intercostal muscle contractions right here. Okay? So we've talked about this. It's in red, but we've said this more than once, right? Airway assessment is not just a moment in time. It's a constant consideration. Okay? Let me ask you, how often do you think you should reassess the status of your airway? At least every 5 minutes, right? If not sooner. If it's critical, you may never not stop assessing it. But if your non-critical patients, be looking at their airway about every 5 minutes. Are they still talking? Are they still breathing like they're supposed to? Even if it's a breathing problem, it all starts with airway. Okay? This is number one. This is the top. So inadequate airway, no signs of breathing or air movement. That's pretty self-explanatory, right? Any sort of evidence of foreign bodies in airway. What are some evidence that you would have there's something in the airway? What do you think? You guys are sleeping tonight. Marbles on the ground. You have kids. What else? So actively choking, right? Throw stridor in there because that's your big red flag. What else? Grabbing their neck, universal sign for choking, right? It's not the Seahawks symbol. What else? Wow. Bunch of Seahawks fans. What else? Just kidding. Good goodness sake. One joke and you guys just quit talking? What other signs are there? What do you think? What skin color? Pale. What's the other side, though? What's more likely? Yeah, blue, right? Red is too much blood. Pale is not enough blood. Blue is not enough oxygen, right? If your airway is closed, what are you not getting? Oxygen, right? Your blood will move around for a period of time, but that cyanotic, that blue is what you're looking for, okay? Inability or difficulty speaking, right? Unusual hoarse or raspy voice. Then we want you to look at their chest movements, okay? Is it rising and falling like it's supposed to? Okay, this is all about tidal volume. Okay, now we don't have a way to measure tidal volume in the field as EMTs, so you can't be like, well, your tidal volume is only 350, which is too low for normal. We don't have that ability, right? But if you look at 100 normal chest rise and falls, you'll pick up on the one that's abnormal. So the only way to do that is every single time you come in contact with a patient, look at their chest rise and fall. Okay? I will tell you the only way to pick up or get really good at listening to lung sounds, and you pick up on really silly things, a pleural rub, right, which is just lung tissue rubbing against your chest wall. Okay, in the back of a moving ambulance, you'll never hear it, right? In a house, you'll never hear it, unless you've listened to 100 normal lungs, and all of a sudden you're like, that doesn't sound right, okay? Assess people all the time. In this class, if you're bored, after we teach you vital signs, if you're bored, get a blood pressure cuff and a stethoscope, listen to lung sounds, take a blood pressure, check a heart rate, check a respiratory rate, do it all of it. Okay, do it 100 times. That way it's easy once you get out there. Okay, that's huge. The one complaint we keep hearing from the paramedics and the EMTs you'll ride with is that you as students still don't know how to take vitals. And in the beginning, I took full responsibility, right? Except for in this class, I'm going to give you 50 hours worth of vital sign taking capabilities. Okay? You can't get it in 50 hours, you're never going to get it. What it is you're not comfortable doing it on normal people, so therefore you're never comfortable doing it with someone who is actually sick. We have the same problem with advanced EMTs. We make them do IVs here in the classroom 15 times, successful IVs, before we let them go start doing IVs on patients, right? Your first IV on a real sick person, you normally fail. And I get students who be like, I went 15 for 15 in a classroom. How come I can't hit the broadside of a barn? Because the 15 for 15 you went were normal, healthy adults. It's not the 89-year-old lady that has spider veins, right? It's not the 9-month-old dehydrated kid who has no veins, right? That's the challenge. You got to know what normal is. You got to be able to do normal before you can do abnormal. Abdominal breathing, abnormal noises. We talked about stridor. We talked about snoring and gurgling, right? What's wheezing? Do we know? How many of you ever heard that term? Because you've ever had asthma or pneumonia or bronchitis or the flu, you've had wheeze. Yeah. So this sounds a lot like stridor, only it's in the lower airway. There is no upper airway wheeze, right? It's mucus built up either on your trachea or on your bronchus that just causes that whistling noise. It's like if you're, how many of you have like chest congestion? Most of us, right? Inhale real hard and then exhale, and you get that rattle noise at the end of the exhale. That's a wheeze, right? If you're a smoker or know a smoker, you can usually hear that in chronic smokers, okay? Crowing is just what it sounds like, right? We usually associate this with kids, and it's just that sound that they make when they cough, okay? Any gasping or irregular breathing is a big problem. One of the terms you'll get used to is agonal, right? Agonal is considered to be not breathing, okay? The best way to tell you what agonal is, it's like a fish out of water, right? You take Nemo out of the pond and throw him on the sidewalk, and it's like a half breath, and they go 40 seconds. And they take a full breath, and they go 3 seconds, and take a quarter of a breath. It's that irregular gasping. When people start to die, it's their body's attempt to blow off some of that CO2, right? So it's not adequate. When we taught CPR to the public, that's the biggest problem, is they would see these people who were breathing, and what they're seeing is that agonal breathing. And so they decide not to do CPR because they're breathing. You just breathe on top of them, right? It's not adequate enough to sustain life. So we talked about retractions, right, with the intercostal muscles. Above the clavicles is also really common, right? Anytime they start using the muscles above their clavicles to breathe, that's a really, really big red flag they're having a problem. The one thing that kids do that adults don't is they get nasal flaring. Okay, when they have problems breathing, they flare their nostrils because they're breathing really hard in and breathing really hard out. Does that make sense? So really pay attention to, and they're nose breathers. That's the predominant way they breathe. So really pay attention to those nasal passages as well as retractions. With kids, it's a little easier, right, because modesty isn't as important. So you should always be looking at the chest and chest cavity of kids, right? Pull their shirt up and look at it. We get farther into middle-aged kids and high school kids and older, you got to be a little more concerned about modesty and, you know, different genders and stuff like that. But in kids, there's absolutely no reason to not check the chest cavity to see if you're picking up on retractions or intercostal muscle use, stuff along those lines. Okay, so here's opening airway. It's really easy. That's the nice thing. So in your primary assessment, if you find an airway problem, then the only thing we deal with in the primary assessment is life-threatening problems. Okay? If they cut their finger off, is it a life threat? Forget it, right? In the primary assessment, not important, okay? We start doing scenarios. We will purposely put things in front of you that are distraction injuries, okay? You walk up and the guy's barely breathing, but we've chopped off their finger or we've open fractured their wrist, right? When you walk up, what do you see? The blood, right? Forget all that stuff. It's non-life threatening. You can deal with it later, okay? So airway is considered to be a life-threatening problem. We got to fix it right now. If the airway is not open, so if their chin's to their chest, if they are face down or something along those lines, open it, okay? Anatomical position, flat on their back, and they belong in a neutral position. Does that make sense? Now, kids and infants do not do neutral very well on their own. Because of the fact that their head is huge, right? We talked about their head being watermelons, and their bodies are so small, they predominantly sit when they lay on their back with their chin to their chest, right? So in infants and kids, you actually pad about 3 inches under their shoulders and give them that diameter they need to bring their chest up to their head. Because of the fact that they have really, really poorly developed tracheas, if you try to take a kid who's in that sniffing position and head tilt, chin lift them, to get them straight, you actually have to hyperextend their neck, right? And their trachea will actually kink the opposite way, okay? Laying like this, it's kink, they don't breathe real good. If you extend them, they kink like that, right? So if you pad their shoulders, you allow them to stay in that neutral position. Does that make sense? So indications of head, neck, or spinal injuries. If this is a non-emergency move, we're going to be concerned about head, neck, and spinal injuries. If they have a mechanism of injury that's known to cause such injuries, okay? You're going to see this term again and again. You'll hear me say MOI, right, which stands for mechanism of injury. What do you think this means? How they got hurt, right? Was it a car wreck? Was it a fall? Was it a gunshot? What was it? Okay? We'll use mechanism of injury a ton next week to talk about guessing injury patterns. Okay? So what are some mechanisms of injury that's known to cause head, neck, or spinal injury? What do you think? Car accidents. All car accidents? Yeah, most, right? We've talked about speeds guaranteed above 50, right? Less than that, it really just depends on the damage and so on. What else? Falls. All falls? What kind of falls, Brandon? Well, for sure, right? 12 stories, yes. What if you fell 10 stories on your feet? Right? So, and I'm picking on you on purpose, so give me the parameters. True story. But what about all falls over 10 feet? 10 feet onto your feet, 10 feet under your head, both can cause spinal trauma? Absolutely. Right? Now, 10 feet into the water, maybe not. Right? So our rule of thumb pretty much is 10 feet. Anything over 10 feet is considered to be a high mechanism injury. Okay? Any injury at or above the level of the shoulders. Okay? Broken bones, stuff like that's a pretty big red flag. Or family or bystanders that tell you that something happened, right? Our worst nightmare is the person who's just laying on the ground. Okay? How did he get there? How did he fall? Was he thrown there? Right? If family can tell me he was walking in the living room, he got chest pain, he knelt to the ground and then laid on the floor, I don't have to hold C-spine, right? But if he's laying flat on the floor and no one saw him get there, I have to hold C-spine. So try to ask questions. Question those bystanders. Did you see anything? Did you hear anything? Did they complain of anything? Did they fall? Was there any trauma? All that stuff becomes important. 2 terms to write down, okay? Write down head tilt, chin lift, and then put some, like colon, right? And then write no spinal injury. Below that, write jaw thrust maneuver and colon, and write spinal injury, okay? That tells you the 2 times that you're going to use head tilt, chin lift, or jaw thrust maneuver. Make sense? All right, so this is the head tilt chin lift, okay? Takes two hands. One hand goes on the top of the head of the patient, and two fingers go on the jaw, okay? Not on the soft tissue, okay? Everyone take your thumb and push on the soft tissue, and what does that do? Closes your airway, okay? Who said it hurt? Push harder. Do it to your neighbor. Let's do that. Put your thumb on your neighbor's throat, okay? So this right here is great as long as there's no spinal injury, okay? You're taking them and putting them, believe it or not, in more of a neutral position, okay? Look at that. So here's jaw thrust, okay? This one is miserable. So you usually got to kneel down. This one you can do standing up if you have to. But you kneel down, you put your thumbs on their cheekbones, okay? Notice position of his thumbs, right? They run right down his cheekbones, okay? You take your fingers. Sometimes you can do it with just your index fingers. Sometimes you got to use multiple fingers. You're going to find the joint where your jawbone connects, okay? Don't push there. That really does hurt, okay? And then it's like a blink or flip with your fingers, okay? You're going to bring your fingers with your thumbs are in position. You're just going to bring your fingers straight up and you're going to hold it. All you do is you pull that lower jaw straight up in the air, okay? Which should, because that your tongue is attached to your lower jaw, should pull your tongue out the back of your airway, okay? Now, this person is unconscious, right? Because that's why you're doing this. How long do you think you can hold that? 5 minutes? $5 if you can do 5 minutes. Most people it's like 2 or 3 minutes and they start to let off, right? So this is great to fix it right now, but this is where we normally start talking about NPAs and OPAs, right? Oral pharyngeal airways, nasal pharyngeal airways, because this is not something you can do for 20 or 30 minutes, right? It fixes the problem right now, but it really doesn't fix the problem long term, okay? Again, we're going to practice this today. You've got to get used to be able to do this without tipping the head. People want to pull real hard. You can't move their head because you're holding spinal stabilization, right? So you've got to do this without tipping their head in any way, shape, or form. I will also tell you that we'll talk about painful stimuli a little bit later. We're starting to get away from sternum rubs, okay? We used to take our hands when we're trying to get painful stimuli and rub your sternum, which causes enough pain to wake you up. It causes damage. It's frowned upon. Believe it or not, if you take the drunk guy who's faking being unconscious and jaw thrust, he doesn't fake unconscious very long. Okay, this is miserable. Okay, it hurts your cheeks, it hurts your jaw. These people are like up, it's like a miracle. Right? You're like, oh, it's good to see you. Don't do that again. I'll put a tube in your throat. So after the airway's been open, now you're going to find a position that makes it stay open. Okay, once you open it, you also want to be aware to see if there's any secretions. What's the only way to see if there's secretions in the mouth? You got to look, right? I wouldn't get real close, but get close enough to see if there's something in their mouth. Okay? Teeth, blood, vomit, objects, whatever. Okay? What type of personal protective equipment should you be doing if you drew the short straw and you're the airway position? Goggles, mask, gloves. Okay? Let's take a quick break right here. It's a good spot to take a break. Stand up, get some coffee. What about the eye flick? All right, so let's talk about airway adjuncts, right? So these are your OPAs and NPAs. So here's what I would like from you, okay? I want you to treat this like a drug. Know everything there is to know about OPAs, everything there is about NPAs. By that I mean know how to pronounce oral pharyngeal airway and nasopharyngeal airway, okay? Nasopharyngeal airway and oral pharyngeal airway, okay? We still get crap from paramedics that say EMT students don't know how to pronounce their own equipment. It makes you look like a moron, okay? Pride yourself. How would you feel if a doctor walked in and couldn't pronounce stethoscope? You would go, why am I in Chewelah Hospital? Just kidding. Kind of kidding. That actually is fairly correct. So airway adjuncts. Airway position and maneuvers are short-term solutions, right? Head tilt, chin lift, jaw thrust, they'll eventually deteriorate. So we've got the two most common airway adjuncts, okay? We're going to talk about when to use them, how to use them, and so on, and then when we get to do skills in about an hour, me and Kayla will talk about each one of these and get you a chance to get your hands on them, okay? So this is the most, what's the best way to put this? The most basic airways possible, okay? I don't mean like EMT basic. I just mean less work, less training, easiest to get your hands on, okay? OPAs happen a decent amount of the time. NPAs aren't horribly common. Some EMTs have done 5 or 6 or whatever. It just depends on the circumstance, okay? So, what's that? They're not painful if you do them right. Don't worry, we're going to mess with you in a little bit. Rules for using airway adjuncts. OPA only on patients that do not have a gag reflex, right? If they have a gag reflex, you cannot put the OPA in. Okay, pretty straightforward. Don't put the curved piece of plastic in their mouth if they gag. Pretty straightforward, right? All of these devices, you need to manually open their airways first. Okay, with oral airways, make sure you do not push their tongue back into the back of their mouth. Okay, it's why we'll talk about it goes in 180 degrees the wrong direction, and then we actually rotate it into place, so you bypass that tongue. Okay? Oops. This is pretty self-explanatory. What do you think the best way to test for a gag reflex is? Put the airway into their mouth. If they gag, they got a gag reflex. Okay? If you're doing airway, suction needs to be right next to you. Because the last thing you want is them start to puke and be like, Brandon, go get the suction out of the rig. Okay? Because if you put this OPA in and they gag, they're going to puke. Go ahead.
I've seen stuff like some EMTs, they just kind of like stick the suction tube down their throat.
Yeah. Yeah, there's also a rule, it's a tricky rule of thumb. If their eyes are closed and you run your fingers along their eyelashes, your gag reflex is attached to that nerve in your brain, and your eyelashes will actually flicker. Right? Paramedics, we do it all the time. If their eyes flutter, they have a gag reflex. Right? It's when they're unconscious. So we try that, and then we just put the OPA in there. If they gag, congrats, they got a gag reflex. And then maintain head position after the adjunct is inserted. Now that's head position, that's not maintain a jaw thrust, right? They still belong in that neutral position. Don't let them go back with their chin to their chest. Does that make sense? The entire time we're doing airway, make sure that we've got suction ready. This is pretty straightforward. If patient regains consciousness or develops a gag reflex, you probably want to take out the OPA. Okay? It's like step 1. We talked about airway personal protective equipment, right? Goggles, gowns, gloves. Or goggles, masks, and gloves. Gowns wouldn't hurt you. Moving too fast, are we good? Fine. I haven't got any cool stories this one. We're trying to get to the slide with cool stories. Takes longer. Good? Sweet. So, oral pharyngeal airway, device used to move tongue forward when it curves back in the pharynx. It's all the way from infant to adults, right? So we can use these in all size people. Okay, all the way down to infant ones are about yay big. Okay, we've got infant ones here. Okay, tiny. All the way to pretty large ones. Okay, there's the range. I'll go back. There's the range, tiny, so on. Usually they're in a plastic container sized from the bottom all the way to the top. Okay, the problem we have with these is the chance of them vomiting, right? It's the biggest issue we're going to have with these. We good? All right, so this flange right here sits on their teeth. This goes in their mouth, right? When you use the BVM, air travels down these passages and allows that air to go past the top. Make sense? So, to size this, you're going to measure from the corner of the mouth to the tip of their earlobe, okay? Or the corner of the mouth and follow their jawline until it gets to the tip of their earlobe. Okay? So you want the device that goes from there to the earlobe. That's the right size. Make sense? Pretty easy. That'll be on more tests than you can imagine. Yeah. Good call. It's a horrible picture. Okay? That's the right size. Now, it's also 180 degrees backwards, right? This will normally go in the other way. When you insert this, you insert it just like that until this right here gets to the back of their mouth, and then you rotate nice and easy and rotate it into place. Because you want this curve to go around your tongue, and then as it rotates, it kind of scoops the back of the tongue and rotates into place. Then that flange sits right on their teeth. Okay? If the person is breathing on their own and you're using this, you still have to provide artificial ventilation. You have to use a BVM with this. Because what you don't want is them trying to breathe on their own, opening their mouth and going, because it'll take the flange off their teeth and then it sucks that piece of plastic into their mouth. Okay? You don't want that. I assure you. Okay, we'll talk about inserting it when Kayla gets here in about an hour. Okay? So this crossed finger technique it's textbook, right? There's other ways to do this. But the purpose of this is the last thing you really want to do is stick your fingers in someone's mouth. Okay? So here's worst case scenario. If they seize because they're hypoxic, they're going to bite down until they're done seizing. Okay? I've transported people that have been seizing for over an hour, which means they'll bite until your finger comes off. So this way is really concentrating on the lip and not on their teeth, right? And it's also crossed, so if they bite down, it should almost cause your hand to like spin out of their mouth, right? I'm a big fan of letting your partner stick their fingers in the patient's mouth and opening it for you, right? Or a tongue depressor also works really, really good, okay? Or a suction tubing, whatever you have. I hate this. This is like my biggest fear, okay? No, thank you. Talked about that. So cross tip goes in 180 degrees the wrong direction. Once it goes past that tongue, you're going to rotate it into place. For kids, pediatrics, I thought there was a picture. Pediatrics, we do not rotate. Okay, if you're using the little one, we don't rotate it 100 degrees. You just drop it anatomical position. Okay? Because of the fact that the soft tissues in their mouth are easily damaged, we don't want to cause that plastic to be scraping. So you just drop it straight in. Okay? So here's the nasal pharyngeal airway. This one's soft and flexible. See, Brendan? Soft and flexible. Doesn't cause as much pain. We're going to shove it into someone's nostril. That's about right. Right? The purpose of this, again, same thing, is to move the tongue and soft tissue forward to provide a channel for air. So this is the thing to remember. This stuff is awesome, right? OPAs and NPAs are great, but let's say you get stung by a bee and you have an allergic reaction, right? And your throat's starting to close. Does OPAs or NPAs do you any good whatsoever? No, because this doesn't, nothing below the tongue, this is even fixing, right? This stuff's great for someone who just can't control their airway because of a body position. Bronchoconstriction, trachea damage, swelling from burns, stuff like that, this doesn't even touch it, right? This is a good starting point, but you've got to be a little more aggressive in airway control. Okay, so here's the perk to it, right? The perk is you can use this for patients who have an intact gag reflex, or they have what's called trismus, which is that clenched jaw. Okay? So let's say they've been seasoned for 30 minutes, and you've decided that you need to control their airway when they're seasoned. This is the one you're going to use. Okay? What does the term contraindicated mean? When you can't use it. Okay? So indication is when you can. Contraindication is when you can't. So let's go back to OPA. What are the indications for an OPA? So non-adequate airway, right? What's the contraindication for OPA? Gag reflex, okay? Indications for nasal airway, still inadequate airway. Your contraindication is if they have clear fluid or blood coming from their nose or ears, you cannot put this in there, okay? The reason is there's a chance they have what's called a basilar skull fracture, okay? I got a chance to go down to the anatomy lab at WSU and look at human cadavers. and pick up a human skull and look at the nasal bone that separates the back of your nostrils from your brain, and it's literally so paper thin you can see through it, right? So any sort of facial trauma can break that cavity that would allow that NPA to travel like it's supposed to, and it can cause some damage. So that's what you're trying to avoid. So any blood or clear fluid coming out of the nose or out of the ears, can't use it, okay? We used to use the rule of thumb. You can still use it. Any sign of head trauma, you should be worried about using the NPA, okay? Comes in various sizes. Notice how it's not in red. You don't have to know the numbers. Measuring tip of the nose to the earlobe, okay? With these, the bigger the size, they're also wider, right? Now, here's the comfort piece of this that provides a little more comfort to patients. You need to use water-based lubricant to put this in their nose, okay? In this class, I'll let one of you, if you want, will drop an NPA in your nose. Your choice. I don't make people do it. It's your choice. What we had happen in the past is we do this on the mannequins, right? So we're dropping NPAs. We've got special plastic lubricant for our mannequins, right? That stuff does not work when you put it in your own nose, okay? If you want one placed in your nose, ask me, and I will open an airway kit, and we'll actually get you the lubricant you're supposed to use, okay? Because the spray stuff we use in this class provides you no lubrication whatsoever in your own nose, okay? So they're laying flat on their back. You take one finger, you grab them by the nostril, and you pull their nostrils a little bit, right? I think there's an anatomical name for it. I call it the pig position, right? Because you just pull it flat, okay? This has a bevel, okay? Notice how it's cut at an angle, right? The bevel goes towards your septum, which is what? The middle part of your nose, right? These are almost all manufactured to go in the right nostril. It can go in the left nostril, because see how it's got the curve? This is manufactured to go in the right nostril. If it won't go in the right, let's say they have a deviated septum, right? That's a great thing to know if they're awake, but if they're awake, why are we doing this in the first place? So you may not know, right? So you might try to put it in their nose and it doesn't work. Pull it out, right? Put some more lube on it, and then go the other side. It's just now going to be curved the wrong direction. Who cares? Still bevel towards the septum, and then drop it into place. Okay? If you ever get a chance to do this, do it. It's just like, it's just rewarding, right? You're like, I have to do an NPA. That'll happen very often. Okay? Let's say there's whatever reason. I've had this question before. Is there any reason you can think of why you wouldn't place 2 NPAs? Any reason that you can't? No, right? Who cares? The downfall is there are some drugs. Narcan is the one drug you guys will be able to give intranasally, right? You give it in their nose. If you drop NPAs, you cannot give the drug through the NPA. Because the way the drug works, it gets absorbed through the mucous membranes of your nose. If you've got this garden hose in there, it's got nowhere to go. Okay? That's the only thing I remember. So push the tip of the nose upward, that piggy position. Head goes neutral position. Advance till the flange sits firmly on the nostril. So, but she's awake and fine. It's no big deal. Go ahead, bud.
Do you mean like if we have 2 NPAs, we couldn't use?
So if you only have one NPA, you just got to administer the drug in the other nostril, right? Just don't put it in the nostril that has the NPA. Do you have a question? Thought you raised your hand. No? They're like, don't call on me. Oh, it's your own fault. All right, so here's suctioning. Okay? So someone's laying flat on their back, okay, and they got a mouthful of vomit, right, or blood or whatever you want to think up while you're eating. I don't care what you think of. Okay? How long do you think it takes to get your suction ready? Because you've got to test it, right? You got to turn it on. You got to make sure it actually sucks, which in this case is a good thing, and then you have to use it, right? How long do you think that process takes? Best case scenario, 15 to 30 seconds, right? This person's laying flat on their back with a mouthful of vomit. All it takes is for them to breathe one time, right? And if all of you take a drink of your water, tip your head back, and take a big deep breath, where does it go? Into your lungs, right? So what do you think is, if you're going to suction, what is the best position for them? Recovery, right? The first thing you do when you go to suction is roll them on their side. Because who knows, I mean, all that blood or that vomit or whatever drains out of their mouth and clears its own airway. Awesome, right? We do not any longer do blind finger sweeps, okay? Once again, do not stick your finger in someone's mouth, okay? Pretty straightforward.
What happens if you, like, they're too big and you can't get them
I have yet to have a person that can happen. I transport a 720-pound patient. Roll them over. Right? I mean, pull them over. Yeah, might take 4 people, might take 10 people, might take a winch. Either way, roll them over. Just don't let them keep rolling. Because then they're face down, and the whole problem starts. Not like rolling. Gosh, you guys are sick. Okay, suctioning is a vacuum device to remove liquids from airway. Got to delete that off the recording. So with this, there's a manual one, okay, which is your worst nightmare, and then there's automatic ones, and then there's ones that are fixed in your ambulance, okay? The manual ones, we call them VVACs, okay? It's a spring-loaded thing that you got to use your forearms to create the vacuum, right? Not very much fun. We prefer the portable suctions that are battery-powered. Okay, there's a picture here in a second. So I want you to look at the dumb numbers that are in red. Okay, they're in red because the NREMT loves this test question. Okay, for a mounted suction unit or a portable suction unit, it's battery powered, right? It has to furnish air intake of 30 liters per minute, and it has to generate a vacuum of no less than 300 millimeters of mercury when it is sucking, right? The way to do that when you're testing it is to put it against your gloved hand or to kink the hose. Right? So on rig checks, I don't know where this, we're supposed to, on rig checks, check our suction canisters. Okay? Doesn't happen very often. Usually it's like, this one's broken when you want it, when you need it. Right? But you should turn it on, make sure the gauge runs to 30 liters per minute, clamp the hose, and make sure that gauge runs to 300 millimeters of mercury. That's what that means, millimeters of mercury. Okay? Blood pressures are measured in this, and the vacuum in this case we're talking about is measured in that as well. Portable suction units, same requirements as the mounted ones, right? Oxygen and air powered or powered by battery electricity, and there's the manual ones. Manual ones are not so much fun. So pieces, you got the tubing, the suction tips, the suction catheters, there's the canister, right? And then usually a container of clean or sterile water. This is a fixed one. Okay, here's the gauge we're talking about that shows you liters per minute and millimeters of mercury. Here's the canister. This is all wrapped up nice and neat. Now, I will tell you the one thing that we all do that we don't think about is that right there is the suction catheter. Okay? Is that sterile when you put that in that patient's mouth? No. If your agencies do this, don't let them. Right? You've just created a non-sterile environment because your TB patient who coughs blood could cough blood onto that, and you get to pass it on to your next patient. It needs to stay in the packaging. Now, I understand that if you want to set this all up, get ready to go, leave this, then connect it, but leave it inside the package, right? Just open it a little bit, plug in the hose, but leave it there, okay? I understand that when you want this, you don't want to have to, like, open the packages and plug in the hoses, but don't leave this unwrapped, right? How many of you would put a piece of gum in your mouth that hasn't been wrapped sitting on a counter? Didn't think so. Make sense? So, 2 types of tips. Okay, there's the rigid tip, and I want you to look at this word right here, yonker. Okay, know how to pronounce it. I don't care if you call it yank hour or yonker, I don't care. But don't be like the Y one. Okay, so a rigid tip is the yonker tip. Okay, this is meant for larger particles. Okay, this is also used to suction out the mouth, and that's pretty much it, just the mouth. You put it in their nose, but it's just, that's mean. Okay? The flexible tip, which we'll talk about here in a second, or the French tip, is usually for the NPAs or for the tubes. Everybody got yonker? Rigid, yonker. Yonker, rigid. I don't care how you remember it. Pretty easy. So, one rule, we're going to recap at the end of this, but one rule is never suction farther than you can see with the yonker tip. Okay? Notice how far that is. Not very far, right? We really only care about that oropharynx because if you think about it, past about right here, you're past the trachea, right? So I don't care what's down here at all. Okay? I only care if it's in that oropharynx. So, only suction as far as you can see. The other one is if they have a gag reflex, don't ram this yonker tip in and make them puke even more. It's pretty easy. The flexible one, okay, or we call these French tips, okay, these can be passed into the nasal pharynx, so you can run these in an NPA. You also would use these with our King Airs or our Combi tubes or our LMAs or our iGels, which we'll talk about, and they're also really commonly used in the endotracheal tube. Okay? These you can actually run down and suction out some of that esophagus to preemptively try to keep vomit from being a problem. Okay? We don't just run the French tip into an open mouth, right? It needs to be going in a device, an ET tube, a King Air, a nasal pharyngeal. Don't just run the tube into their mouth and try to suction out that way. It doesn't work very well. Good? So here's the downfall. It kinks, right, because it's a flexible tubing. The other one is with really thick vomit or thick blood, this clogs extremely well, right? So you might have to use the Yonker tip for the bigger particles inside the mouth. When you're running that flexible tip, you measure this the way you measure your OPA, right? So measure from the corner of the mouth to the earlobe, mark it, and that's how far you're going to put that tube into their mouth. Does that make sense? It's pretty easy. So there's a look at it. Okay, if you were going to stick that in her nose for whatever reason, measure it like you would the OPA. We talked about infection control, right? This is an airway. So gloves, mask, goggles. So here's the other rule. Rule number 2, you never suction longer than 10 seconds unless the patient continues to vomit longer than 10 seconds. Okay? If they're puking and puking and puking and puking, you're just going to suction and suction and suction and suction. But normally, never suction longer than 10 seconds. Because not only are you causing to suck oxygen out of their airway, but you're also not allowing them to breathe. Right? So, suction, take a break, suction, take a break, suction, take a break. 10-second increments. Here's the other one. So the Yonker tip and the French tip both have spots that you have to occlude to make it actually suck, right? Because the Yonker tip has that window. If the window's not covered, then it doesn't actually create a vacuum. So place the Yonker tip in the mouth and then occlude the window and make the actual thing provide suction. So we say it as suction on the way out, not suction on the way in. Okay? Never suction as far as you can see. Never suction farther than you can see. Never suction longer than 10 seconds, and suction on the way out, not on the way in. Okay, those are your 3 big rules when it comes to suctioning. Make sense? Me too. All right. Oh, and then test suction. Sure. So, definitive care, right? We talked about definitive airway. Define definitive care. Someone define it. What do you think? Take a wild guess. You guys have been sleeping way too long. Take a stab in the dark. I told you what a definitive airway is, right? Say again? You close. Definitive care is the very best care possible. So in EMS, what is definitive care? No. What is definitive care? The very best care possible is what? A hospital. Right? In the pre-hospital world, our very best care is a paramedic. Right? But in EMS, our definitive care is a hospital. Okay? I know this is way early. I want you to write this down. The very best treatment for multi-system trauma, okay, I'll stop right there. The very best care for multi-system trauma is rapid transport. Okay, the very best care for multi-system trauma is rapid transport. What does that mean? Multi-system trauma means what? So there's organ failure. What else? Yeah, it's blood loss, it's broken bones, it's nasty, nasty shock. Shock in multiple parts of your body, right? It's the stuff that you see in movies. Okay, car accidents, multiple gunshot wounds, long falls, they're broken, they're bleeding, they're unconscious, they're a mess, right? Everyone gets wrapped up in doing all this treatment on scene. Well, let's splint this wound, let's give them IVs, let's intubate. That's all. None of that stuff matters, right? The very best thing for them is get them to a hospital for a doctor who can actually fix the problem. I used to make the joke that EMS doesn't fix anything. We just prolong death long enough to get them to a hospital. That's all you're doing. Keep them alive long enough to get them to a doctor. Doctor fixes things, right? He surgically occludes a vessel that's bleeding. Good for him. What do? You apply a tourniquet. That's not a permanent fix. It just prolongs death long enough to get them there. Okay? So definitive care, that should be your goal. So pay attention to your on-scene times. Okay? If they're critical, get them to a hospital. So this is probably one of the more difficult decisions you'll have to make, right? Besides your own personal safety, you'll be staring at a patient. You have to make that choice. Is it better to do nothing and drive them to a hospital, or attempt to do something and then drive them to a hospital? Okay? On scene, you're going to have to decide, do I need a paramedic, right? Some of you might work in systems where you get a paramedic on every single ambulance, or that your partner is a paramedic, or no matter what the call is, a paramedic is sent to you. Those systems are awesome because you never, ever have to think about whether or not I need ALS. And that's how you usually hear me say it is ALS, which stands for Advanced Life Support. I will tell you that if you go to Colville, okay, Colville, Kettle Falls, Republic, you know where their nearest ALS is? Phelps Field, right? Which is awesome as long as it's a clear day and the helicopter can fly. If not, their nearest ALS is Brewster, right? Which is also a helicopter, which means if the weather's bad, you don't get them. So get used to in this class asking for ALS. You work for District 10, you're used to getting an ALS paramedic, that's awesome. Not in this class, right? You got to ask for them. Don't take what you already have and apply it to this class. And the second one is you got to choose. Do they need to go to the nearest hospital? They got to go to the best hospital. What's the time frame we're talking about? 30 minutes. Okay? That's huge. So let's say you were unable to manage an airway at the basic level. I hate the term basic. Okay? So let's say at the EMT level. What advanced resources might be available to you? So you, for advanced life support, what do you have access to? Helicopter? What's that? What? Paramedics. Or maybe you're a BLS unit, an EMT unit that just runs to a hospital, right? Maybe you don't get a paramedic. Go to a hospital. There's doctors and nurses. Okay? They're a little more advanced than you. So I want you to watch this video. It's bloody. If you pass out the sight of blood, go ahead and close your eyes. This is an attempt at an ET intubation. It's extremely bloody. So they're going to go to a little more advanced procedure, which is called a surgical crike. They're going to take a scalpel and cut a hole in his throat and put a tube in that way. Okay? So you'll kind of see the progression of this. So notice how much he's fumbling around the airway? Forget it. That's a scalpel. So what do you think you can do to help in that process? What do you think? Well, okay, I'm looking for the positives. I'm on board with get your hands out of the way. Besides that, what do you think? So you could grab stuff for him, right? What else? Because adrenaline plays a pretty big role in this, right? What else can you do for him? You could hold his head, right? What else? You could hold, he's unconscious, which is a nice thing, but they are conscious, which this can be done on a conscious person. You don't want them reaching for the scalpel at their throat. What else? Suction's a huge one, right? I will tell you that surgical crikes go one of two ways, okay? There is a very small window that we're aiming for, okay? You take your fingers, there's a big gap in your cricoid-thyroid membrane, right? For guys, just below your Adam's apple, okay? That's what we're cutting in between. So we cut a vertical cut with our vertical cut with our scalpel, and then we cut the membrane, which gives us direct access to your trachea, okay? If you're an inch to the left or right, you cut into the carotid artery, okay? So that's where you're going to need suction, okay? Because that's going to be a big oops. These also have a tendency to bleed quite a bit, even because you're cutting skin with a scalpel. So yeah, suction is huge, okay? What else can you do to help them? What else do you think? Once this is in place, how can you help them? Listen to lung sounds. You could squeeze the bag for them, right? You can hang on to this thing. What were you saying, Mark? Yep. And I will tell you that it's hard. The color change you're talking about is actually a CO2 detector, which we'll teach you on Thursday, okay? But you can watch for, are we getting good chest rise and fall? Okay? It's pretty obvious what caused this guy to be unconscious. What do you think? You don't know it's a car crash. Could be shot, right? But what is it? Trauma. So when his chest rise and fall, you want to see, is one side rising, their side's not rising, are there broken ribs, all that stuff, because the paramedic, or the doctor in this case, got a lot of crap on their mind. They need to have some help from us as EMTs, right? All right, so special considerations. Facial fractures and injuries bleed a ton, okay? So you've got to provide suction. Also, if their face is broken, they may not be able to control their own airway, okay? Which means you may have to give them a more definitive airway. You got the supraglottic, right? You got your king air. That's all you can do. We don't have the access of using the the ET tube. I'll go back, don't worry. Just want to make sure it was the next slide. We got that down? All right. So before you start telling me what story you heard about this guy, I will tell you it's probably not true. But first off, is his airway open? Yep. Is he breathing adequately? Yep. How do you know? He's sitting up and talking. Right? Your vocal cords aren't on your tongue, right? He's conscious and alert. His airway's open. He's breathing adequately. Do you need ALS? Yes. Right? I will tell you, 10 years ago, we would tell this guy, you got to lay flat on your back because that's the position you belong in, right? Which you would kill him. Right? Yeah, he drowned. Right? Now, can you suction him while he's sitting up? Absolutely. Right? Because he's going to need it. Okay, he looks like Predator. Horrible, right? So the story behind this, believe it or not, no, it wasn't a gunshot wound. No, it wasn't a dog bite, which there are two things people have said. This was a military guy, and they used to crimp blasting caps in their teeth. And he crimped the blasting cap to connect the two wires, and the cap fired and blew his face off. Right? So, airway's open. It's adequate for now. Okay, so let's say this guy goes unconscious. So you lay him flat, okay, that's fine. How would you know where to suction? Never as far as you can see. The good news is now you don't have a mouth, so you can go a little bit farther. What else? How else would you know where the airway is? Okay, so if you can determine if that's the tongue for sure, what else? Bubbles, right? As he's exhaling, it's going to create bubbles because this is going to fill full of blood. So you suction the bubbles, right? Because that's where air is trying to escape. That's where air's got to go in. Okay? Kind of keep that stuff in mind. Obstructions, we'll talk about this a little more in depth. Denture pieces, if they're not a problem, leave them alone. If they're secured, leave them there. If they're not flopping out, leave them there. Okay? If they're dislodged, if they're sitting in the mouth, they keep falling off, then great. Take them out of the mouth, put them in a Ziploc bag, put them on the patient, make sure they go to the hospital with them. Okay? That's huge. We'll talk about pediatrics here in a second. This is the same picture. This is the second time you've seen it, right? It's 2 of like 17. One of these days I will put this on a test somehow, some way. We talked about not hyperextending their neck, right? Again, see the difference in the trachea when they're laying flat, right? So you got to pad those shoulders to bring that up to that neutral position. All right, so here's my one bad story, not one bad, this chapter bad story. So we're going to talk about failure, because airway is one of those times that you're going to fail, right? The NPA doesn't work. The OPA doesn't work. Or you drop the OPA, they gag, they vomit. So you drop the King Air, you're having a hard time getting to feet or whatever, okay? Anytime in this class that you fail or you start to get frustrated, even in a skill setting or in real life, right? Slow down, take a breath, and ask for help, okay? I can't get this NPA to work. Great. What's the definition of insanity? Trying the same thing over and over again, expecting different results, right? So if you drop the NPA in the right nostril and it doesn't go, and then you try it again and try it again and try it again, it's never going to go. So what do? Try something different, right? Put it in the other nostril. Shocking. You got 2 nostrils, thank God, right? So anytime you get frustrated, take a breath, slow down, ask for help, right? Try something different the second or third time that you're attempting this, okay? So my one horror story, anybody know what this is? Take a guess. So it's a palate, but it's a denture palate, right? This normally has these spots right here are for teeth, right? So we get this guy in Springdale riding his motorcycle. We assume has some sort of medical emergency and smacks the highway, right? Goes through a barbed wire fence and basically just chops him up in little pieces. He's still in one piece, but he's cut all over the place. So we get there. He's unconscious. He's unresponsive. We got bleed. We're trying to do tourniquets. We're trying to do all this whole process. And we start to bag him, so we're ventilating him. He's getting good chest rise and fall. He's getting good color change. But since he's trauma, the paramedic's like, yeah, let's intubate him. So we're like, perfect. So we're laying in the highway. Paramedic tries to intubate. And again, it's that looking in his mouth trying to see vocal cords, right? Vocal cords are white, and that's how they distinguish them between the rest of the mouth. So the paramedic's looking. He's looking. He's looking. I can't see vocal cords. So we try to stick the King Air in, and the King Air won't go in his mouth. So he bails in the King Air. Same thing, right? Takes a big, deep breath and is like, okay, let's try this again. So we bag him. We're getting good chest rise and fall, so we know there's nothing in his mouth, right? Because if you're getting air go through, there's no reason why this shouldn't work. So bag him a couple of times. We're like, awesome. We stop bagging. Runs the laryngoscope blade in his mouth. He looks. He's like, there's no vocal cords. I can't see him. We suction. He's like, nope. Drop the King Air. Grab the King Air. Can't get the King Air in. He was like, you know what? To hell with this. Let's just quit, right? So go back to bagging, getting good chest rise and fall. We decide we're going to fly this guy out. MedStar lands, respiratory therapist walks over and says, why is he not intubated? And we're like, we tried, and you know, we tried the King Air, doesn't work, and he goes, there's no reason why it shouldn't work. We're like, we know that, thank you, but it doesn't work. And he goes, I haven't missed an intubation in 10 years, move. And you should have seen us went, go ahead, right? Gets on the ground, runs the laryngoscope blades, he's like, I can't see vocal cords. No shit, right? We've been down this road. So he's like, give me the King Air. And it was like, okay. Flip him the King Air. He's like, the King Air doesn't work. We know, right? So he goes, let's just bag him. Perfect. So put him in the helicopter, fly away, right? Our medical director is on call at Sacred Heart. This guy comes into Sacred Heart as a trauma. And my medical director sends this picture to my cell phone and says, what is this? And I went, I don't know, what is it? He's like, it's a denture plate. And I was like, good for you. So this guy hits the highway, right, which knocks all the teeth off his denture plate, and he swallows it. So the denture plate went down and sat right on top of the epiglottis. So with the blade, and notice what color this is, which is the perfect color of your throat, right? When we would bag it, it would create a pressure, and the denture plate would actually flip like a little valve. So it would flip sideways and let air go through, and as soon as the air would try to exhale, it'd flip back and occlude. So the King Air wouldn't go in because it was pushing on this. The laryngoscope blade would, or the ET tube wouldn't go in because you could never see it. He'd bag just fine, right? So The only way they found is they ran the video laryngoscope down and could see the outline of it. And I'll show you the video laryngoscope on Thursday. They could see the outline of it and went and stuck. They're called Miguel forceps. They're big, giant, long